Today, we're going to go over neuroleptics, also known as antipsychotics. You know, antipsychotics is probably not a good term for these medications. And because there's a lot of psychosis is just one of the symptoms associated with a whole other things. Um, um, so what are they called just antipsychotics? I don't know. It's maybe better to refer to these as dopaminergic agents, things like that. So I think in our industry, we're moving away from the labels, like they're schizophrenic or something like that, or they bipolar, things like that, to the actual mechanisms. And the receptors in themselves have to have their own level of respect because these are magnificent molecular machines that basically manage the details of your life without you having to get involved. And I would say those are very interesting structures to sort of understand how they work and how they operate. So we're going to go through typical versus atypical antipsychotics. And if you're studying for step one, step two, or step three, then I think you're going to really know this, particularly in step three. Those first two clinical experiences, I think if you understood the differences between typical and atypicals, I think it's going to make things easier for you. And most importantly, what I'm going to do is focus on the targets. You know, with AI in healthcare, I think it's going to revolutionize learning. Because you can get the response you're looking for, as opposed to a different response that someone gave you. So I think AI is going to really be able to simplify all this stuff. At the heart of it, I don't believe this stuff is complicated at all. I think it's the person explaining it in the context they're explaining it. So hopefully I'll be able to simplify some of this stuff first for you. But first, let me try to find the targets of the drug first. So let me go here. And I'm just going to just look like Google to try to keep things simple so you have opportunity to sort of. So first, let me show you the targets here. We're just going to briefly go through a few things. Okay, so let's say here, mesocortical. You guys remember this mesocortical pathway? Schizophrenia, when it's damaged early on during the pre-pubertal stages. When this is damaged, this network is damaged right here. It can result in symptoms we label as autism in these pre-development, early developmental stages. But after they cross certain developmental milestones, damage to the same mesocortical pathway can produce positive symptoms of schizophrenia when the network is hyperactive, and negative symptoms of schizophrenia when the system network is hypoactive. And we can see the patient present in two different modalities when we see the patients in there. With hyperactive symptoms, it could produce a lot of agitation, agitation combative aggression, sort of like glutaminergic. The excessive dopamine causes the excess release of glutamate, and the glutamate is the excitatory neurotransmitter. And so that's why the positive symptoms can present with a lot of disruptive behavior, agitation, a lot of energy injected into the situation. Same thing, different with negative symptoms. That's a lack of symptoms, sort of withdrawn, and a lack of engagement and things like that. The negative symptom component may result as a lack of producing all the substrates needed to sort of operate the machinery. And so the hypoactive state is considered more of a deficient-like state, whereas the hyperactive is more of an abundance of too much of the stuff. But this is the target in schizophrenia. This is the target for positive symptoms, negative symptoms. And so really you're looking at this network, you're going to say, you want to say, oh man, which category do I use? Typical, atypical. But here's the target. Let me look at the receptor profile on the mesocortical pathway. Okay, let's see what it comes up with. Look at this. Can you believe it here? Dopamine receptors, right? The mesocortical pathway uses dopamine receptors, D1 receptors, D2 receptors, right? Okay, these receptors are involved in mediating function like attention, executive functioning, regulated from the prefrontal cortex. We got that. Okay, dopamine receptor 1-2 perception. Then also on here are glutamate receptors, right? We also have GABA receptors. Remember, look at this. Glutamate, there are only two neurotransmitters that's located basically in all tissues. It would be glutamate, which is excitatory, and GABA, which is inhibitory. Yin and yang, yin and yang. We want to keep that balance between the two. So on this medical cortical pathway, are glutamate receptors that can really activate this system. So you want to be able to choose medications that should be able to target this glutamate. Here, GABA, GABA receptors on it. So in many cases, we have to use benzodiazepines along with the antipsychotic medication, whether it's typical or atypical, so that GABA receptor also on those metacortical pathways can sort of help reduce the agitation, combativeness, and aggressiveness. Then they have other receptors here. Okay, so look at these three things: dopamine, glutamate, and then GABA receptors. Okay, so next, if those are the receptors on the mesocortical pathways, then let me just look at, if we look at typical antipsychotics, what do they target? You look at see what receptors they target. So we know what's causing this. Where are the receptors on? Now we know the receptors on the network. Okay, well, what typical antipsychotic can I do that would match those receptors, right? Let me add another field here. And so I'm going to say typical, okay. Describe the receptor profile, FILE. Okay, y'all know I can't type. I can't type and look at the same time. I exposed that. Okay, I exposed that. Okay, let me see here. Okay. Look here. Look, typical antipsychotics act by blocking dopamine receptors. That's why we want it, right? Which is thought to be the main mechanism of their antipsychotic effect. Why? Because here it is on the pathway right here. There they are right there. We're hitting those receptors there. They also have varying degree of affinity for other receptors. Right? Okay. So here, more detail. Here, the D2 receptor blockade. So the typical antipsychotics are known for potent blockade of the D2 receptors, particularly in the mesolimbic. We'll talk about that a little bit later. Pathway. But look here, there it is, the D2 receptor blockade. So that's how we, now here, look at this, a potent, see they are known to the typical antipsychotics are known for potent blockade. That's it. The difference between the typical and atypical when you need it is potency. Why? When the patient, many times you have people who come in that decompensated state, which represent more of a hyperglutaminergic state, and so they're agitated, combative, aggressive. And you have to depersonalize these symptoms for the individual because the network is malfunctioning. And you can't assign responsibility to the individual. You have to be professional and look at the symptomatology and figure out the networking and try to intervene. So in a situation, emergency room, combative, aggressive, agitated, just suffering, would you choose a potent blockade or dopamine or just a regular one? I would say potent one. And the reason why it's called typical is because you're likely going to have side effects to it. And side effects are some of the things you may want. It may need to reduce the psychomotor agitation and combativeness and aggressiveness. It may calm them down. And you want those things. Okay, so here in the typical receptors. Also, look here. Okay, they do, but mainly here. While D2 is central, atypical antipsychotics also interact with other receptors. I'm not sure what percentage of other receptors. This would be, so I would say around 10%, combine all those together, maybe 10%. I'm not a neural psychologist, neurologist, whatever that is, so I may be misquoting this, but I think the other receptors are minor population here. So mainly with the typical antipsychotics, it's going to hit that D2 blockade. Now, the other things like the cholinergic and the histaminergic, they may result in some sedation and things like that. And I think this histamine receptor here is significant in typical antipsychotics because it's through blocking the histamine receptors that can result in the sedation. So these typical antipsychotics can be very potent in blocking the dopamine and reducing just the hyperactivity of that mesocortical pathway. And it also hits those histamine receptors to sort of help create some degree of sedation, sedation for the patient. Now, here, if we block these cholinergic receptors, it's going to have anticholinergic response, meaning dry mouth, blurry vision, and constipation, which are the usual side effect profile for patients with typical antipsychotics. So if I give you these shots, then you may have dry mouth, blurry vision, or some degree of complex constipation or muscle stiffness and tightening, and that's what you want to watch out for. So this is a profile for the typical antipsychotics. Now, let me look at the receptor profile for the atypical. Okay. I don't need a question mark. Let's see here. Atypical antipsychotics, also known as second generation, are more varied receptor, have a more varied receptor binding profile compared to typicals. That's what I wanted to point out there, right? So the atypical antipsychotics are used to really manage that mesocortical pathways and things like that, but it's primarily targeting dopamine. You can get some sedation because it targets the histamine receptors, and you can get side effects like dry mouth, blurry vision, constipation, because it targets the it blocks the acetylcholine receptors. And so those are the typical profiles for typical antipsychotics. Now, atypical antipsychotics, let's look at the range of receptors, right? So look, dopamine receptors, right? Look, a lower affinity and occupancy for D2 receptors compared to typical. When they said potent, which would be higher affinity and more potent. This loose binding or rapid dissociation here, this loose binding or rapid dissociation from D2 receptors is thought to contribute to their lower risk of EPS, right? Okay, so remember on the typical, it's very potent, just the D2 receptor and some minor things. I think sometimes the use of Haldol and the fear that Haldol can cause sedation is a little bit overrated, because the main target for those atypical antipsychotics are the dopamine receptors with minor histamine. So sometimes we may have to give other things along with it if the patient is acutely agitated to sort of help with that psychoticism. But look here at the atypical. So now it blocks serotonin receptors. Remember, the same thing as SSRIs. Actually, SSRIs are selective serotonin reuptake inhibitor medication, and it targets the 5-HT2 receptor. So here, the atypical ones also target serotonin, and that's why we use it for depression. That's why we use the atypicals like Seroquel, like Abilify, for Risperdal. There's all of them been used for bipolar, because it can also use the antidepressant effects of targeting the serotonin receptors. Here, it also has, let's see here, it also has some noradrenergic receptors too, depending on some of them. Other receptors, atypical antipsychotics also may interact with other receptors, histamine receptors, muscarinic receptor, alpha adrenergic receptors. Some of the different antipsychotics have different binding affinities for these different combination of receptors. And so it'd be interesting to look at the chart that shows all the medications and then all the receptors and things like that. You need to just take a look at that to see if it exists. I may show it one time. Okay, so now histamine, muscarinic, alpha adrenergic receptors. Okay, and then look, partial dopamine agonist. Yep, Abilify. Yeah. Look at these things. Yeah. I don't have too much experience with this one. My population is primarily a Medicaid population, so I don't get a chance to use as much of the newer medications. And the ones we use they're evidence based, so I don't think it's less care. I think I have more evidence behind what I'm doing. I'll wait till the newer ones have more evidence behind it before I start incorporating them into my treatment. So in essence, the broader and more complex receptor binding profiles of atypical antipsychotics is thought to contribute to their range of therapeutic effects and their generally better side effect profile than typical antipsychotics. Yeah. So mainly that's the difference between the two. And let me see if I have any questions here for now, okay? Let's see. Hey, Max, how's it going? Hey, Max, how's it going, buddy? Okay. Great. Hey, buddy. I'm really excited about this study, too. Okay. Are atypical antipsychotics truly safer, or they bring new risk? I think all of them are safe. I think all of them are safe. Considering the circumstances, patients come in with a psychosis, agitated, combative, aggressive. Of course, these medications are safe. I think they, they're safe. I think there's more concern over them than I've actually seen them do harm. Let me do this. Let me see if I can give a list of the typical antipsychotics. That'll be interesting. Say, give it from oldest to newest. See if we get some structure here. Great. This is amazing. It's amazing. This is amazing. Right? Okay. So, Thorazine, 1954. So, I use this a lot. I really don't use this. I think this fluphenazine is Prolixin here. I keep forgetting what this is. Okay. Use Haldol a lot. So here, I mainly use Haldol and these two. I don't, and then fluphenazine is my backup. So I really don't use all the stuff here. I don't think we have it on formulary. So these are the typicals. Let me try this. Of the brand. Please list the brand name and generics names for typical antipsychotics. I don't want to start paying stuff. Okay. Okay, great. This is great. Man, this is impressive. Okay, so um, so here are the three I use. Thorazine here. Okay, so Thorazine was the first, huh? Yeah. Okay, and then flufenazine, which is Prolixin here. Okay, and then Haldol, which is here. I don't know anything about these. To be honest, don't know anything about these other medications. They may be used in other jurisdictions in other countries and things like that, not available. But yeah, here are the ones that I use. And so typically, if they were to come in very agitated, combative, aggressive, I would start off with Haldol, right? If Haldol didn't work, and if I needed something weaker than Haldol, then I would probably go with Prolixin. Then something stronger, Haldol, and then if Haldol didn't work, then I go with Thorazine, and those are the basically three medications that I use. And as you can see, when we round, in most occasions, I have to schedule Thorazine 3 times a day. And in many cases, we have to give them IMs to sort of help reduce the activity in that mesocortical pathway. But these are the names of the typical antipsychotics: Thorazine, Prolixin, the weakest, then Thorazine, then Prolixin, then Haldol, then Thorazine. All right. But if you had a text question, I'd probably go with Haldol. Prolixin is one of those older medications that we use as psychiatrists, but I'm not sure if it's going to store up on a text question. So Haldol will probably be the first, and then Thorazine the backup. So the next question is this. Let me see if I can clear the brand out. Yeah. Okay, for atypical. Okay. What I thought Clozaril was. I forgot all about Clozaril as a typical antipsychotic. There's a difference between Clozaril, okay? But here, Clozaril is for when nothing else really works. If it's really treatment resistant, Clozaril is a very effective antipsychotic, but it's associated with agranulocytosis. And so you have to monitor it almost every week up until a certain point. Then you go from 2 weeks and you go from a month. And the patients on this medication are actually entered into a registry where the registry follows them and makes sure they've had the appropriate labs and things like that. Okay, so let's look at these. Risperdal, okay. Zyprexa, Seroquel, Geodon, Abilify, Invega, Latuda. Okay, and so this is pretty much the combination of atypical antipsychotics we use. And this is like your first combination of antipsychotics group of medications on the outpatient basis, right? So if someone's coming in with some symptoms of schizophrenia, some voices that's not agitated, then you want to go with the second generation, these atypical antipsychotics, right? And then if they're having mood symptoms to it, the atypicals are going to target serotonin, so they're going to have some antidepressant benefits associated with it. And I believe almost all of them also have the indication for bipolar disorder. So if you don't want to go to Depakote, if you don't want to go to lithium and everything, then you can look at an atypical antipsychotic as something to treat the bipolar or the mood disorder, things like that. And these work very well. Okay, let's see. So here. Okay, hey Max, what role will future medications play in balancing efficacies and side effects? It's going to be tough to develop newer medications that target dopamine because look how many we have. What about the medications that target glutamine? Um, um, So I think that we're likely going to see innovations in areas outside of dopamine. Like in areas of glutamate. Let's say if with GABA, even if you can make medications for GABA that doesn't result in um, dependency, it'd be really interesting. Hello, Jazzy 2928. Umber, hey buddy, what's the best way to prevent tardive dyskinesia in patients who require long-term antipsychotic therapy? Lower dose and try to get them off the medications during periods of times where they don't have any symptoms, right? So if they have any periods of times where they're symptom free or the symptoms are not as intense, I always try to take them off the medications. And in fact, for these antipsychotics, it's very important, as you'll see when I round, is I always document if the patient is on one or more antipsychotics. And then also you want to make sure that you want to make an effort to reduce their dose of antipsychotic medications. So you want to, as their doctor, to make sure that you only have them on the minimum necessary. And if they don't need it, you take them off. And although there's surveillance and things like that um, helps that. Okay. Okay. Hey, buddy, how's it going? Atypical antipsychotics have increased metabolic risk, usually due to serotonin impact. I agree, buddy. I agree. And not all atypicals, but many. I agree, buddy. I agree. Um, okay, and I think that's it for today. I don't think I want to go any further. We're at 26 minutes, and I wanted these lectures to sort of like stay around 20 minutes. So sorry I went over. If you guys have any other questions, please let me know. You can put them in the comments, and I'll try to respond. But until then, choose your typical and versus atypical wisely, guys. And read out. Take care, guys. Ciao. We're going to go over the mechanism action of antipsychotics, also called neuroleptics, and we're going to see how they work. Um, we have a lot of interesting discussions about this. Um, a lot of interesting discussions about the mesocortical pathway, the mesolimbic pathway. We went through the basal ganglia, and we learned a lot. And these pathways are very interesting. So now we're going to look at the medications themselves, and we were on this topic of typical versus atypical antipsychotics, and I guess you look at the typical first. But Ms. Watts, how are you doing today? How you doing? It's a pleasure to see you.
Hey, Dr. Reed, I'm doing good. It's a pleasure to see you too. Thank you. How you feeling?
I'm great. I'm great. What you up to?
Studying and watching.
I hope this is helpful for you.
No, yeah, it's super helpful. It's
You
super
say,
helpful. I
you
love
say no, yeah. Would you say no, yeah? It's super.
it.
Yeah. I hope it's helpful for you, huh?
No, yeah, it really is, especially just going over like all the pathways and then now doing like the typicals versus atypical is just like always like a great like refresher. And then I'm just always like learning new stuff that I didn't know. So no, I love it and just keep it up and keep being thorough. I appreciate it.
I'm trying to do it all in 20 minutes. I know y'all don't have much time. The students, they gotta go. They gotta get it and go. And, I'm
Right,
trying
right.
to,
Straight to
you
the
know,
point. I love it.
yeah. I hope it's not too much though.
It's not too much. It's not too much. I'd rather have too much than too little. So keep it
And
like this. Keep, making sure that our brains are just like thinking and thriving and those, neurotransmitters going and creating new pathways. So yes, keep going, keep going. Never
um,
too much.
and then this AI is very useful, isn't it? I mean, it
Mm,
seems like it explains it in a very simplified manner, and it's just there.
yeah. But it's just always good to just, even though it is definitely super helpful, that's why it's always good to still, be book smart because sometimes, the AI, sometimes they grab information from places that are like, wait a minute, that's not what that's supposed to
Oh
do.
yeah, yeah. Your AI is only as accurate as the data you put in it.
Hmm.
Isn't that something? You know,
Yes.
physicians are actually going to be data miners. at this point. I think it's going to be a change.
Me too.
But so anyway, here we're going to go through some of the antipsychotics and the mechanism action of antipsychotics. So I have here, I'm just going to continue to use Google right here. And let's see. First, let me look at the typical antipsychotics. These are the more potent antipsychotics, remember? So, okay, explain. You know, I can't say the mechanism action for typical antipsychotic. Let me say that. I think we have to go to the individual medication, but let me look here. Okay, block dopamine receptors. So one of the typical medication is for antipsychotic for. Let's see, hold on here. Actually, let me change this search. You know, usually remember those tables where they have a list of the antipsychotic and then they have all the different receptors they'll target. Let me see if I can search differently. What are let me try it differently. Okay. List the receptor profiles for brand and it's brand and what's the other brand and other name? I forgot the name. The other name for brand and okay.
Generic,
yeah. Okay. Okay, typical antipsychotic receptor profiles and examples. Thank you so much. Appreciate it. Okay, so here, okay, and here's the list here. Okay, there's the list. Okay, here's the generic name. There's this. Okay, so here's the list. Okay, typical antipsychotics, receptor profile and example. Typical antipsychotics primarily block D2 receptors. Okay, we went through that, and we went through the atypical, have a fuller range of receptors like the norepinephrine, serotonin, histamine, and receptors like that. Okay, here, besides their main effect on dopamine, typical antipsychotics exert some of the effects such as noradrenergic choline. We went through that. I'm looking for differently. Okay, and so I'm going to do the mechanism of action for Thorazine. Okay, so let me get here. Okay. Okay, so Thorazine is a first generation antipsychotic that acts as a dopamine receptor and antagonist. Now, Thorazine is when I'm having challenges with agitation, like if I'm experiencing having clients who are experiencing very severe agitation, then I'll likely go with Thorazine as a last resort, right? Because it's very potent, and I'll likely give it IM. So let's look at this Thorazine and how we're going to sort of decide on how to use this in sort of an urgent situation. So specifically, its primary mechanism of action is in managing psychosis, is believed to be related to its ability to block the D2 receptor. Okay. It fits into the same receptors where dopamine would normally bind, preventing dopamine from activating these receptors, right? So it fits there and it prevents the dopamine from activating the dopamine receptor. This blockade of dopamine signaling is thought to reduce the overactivity of dopamine in certain parts of the brain areas, which are implicated in positive symptoms of psychosis, such as hallucinations and delusions. Remember, we are looking at the mesocortical pathway, and hyperactivity in the mesocortical pathway creates the positive symptoms of schizophrenia, right? And we need to and that is secondary to excessive amounts of dopamine. In addition, the mesocortical and mesolimbic pathway have glutamate receptors. Glutamate hyperactivity leads to overstimulation. It's just more hyperactivity. So you can see when the system malfunctions, you can see how people come in agitated, combative, and aggressive. It's really a discomforting state for them. It's important that we sort of relieve them of these burdens right away. So, so the Thorazine blocks the dopamine receptor, and therefore the receptor site is occupied, so dopamine can't get at it. Block the receptors. All right. Besides blocking dopamine receptors, Thorazine also exhibit antagonistic effects on other neurotransmitter systems, including serotonin, histamine, norepinephrine, and acetylcholine. The same crew there. Serotonin, you might as well look at them as a team. Serotonin, norepinephrine, histamine, acetylcholine, that's just your crew. Everything is like GABA, glutamate, dopamine, and then all the backups are like those three, Well, at least in schizophrenia. These additional actions contribute to both the therapeutic effect like sedation and antiemetic properties. Great. We're going to look at the molecular formula. Look at that. Here's the molecular structure of Thorazine. Pregnancy category C. The pregnancy category of a medication is an assessment of the risk of fetal injury due to pharmaceuticals. So it's a category C. Okay. All right, that's Thorazine. Let me look at Haldol real quick. Okay. Haloperidol, first generation or typical antipsychotics. Yep. Look, blocks the D2 receptor here. Now, I don't think Haldol has as much connection with the other receptors like histamine or things like that. Here, however, its mechanism extends beyond dopamine receptors and it exerts its effect by same crew, noradrenergic, acetylcholine, histamine. We have it right there. Okay. Next, that's for Haldol. Now, the other medication, typical antipsychotics I'm familiar with using is Prolixin. So Prolixin here. So I primarily use Prolixin first. I experienced that to be a little bit more milder than Haldol. And then if Haldol doesn't really work, I can go to Thorazine. So let me look at the make up this Prolixin here. Okay, let's see here. The mechanism of action of Prolixin is classified as a first generation of typical antipsychotic, right? Blocking D2. Same here, antagonism at the D2 receptors. So, here, beyond its primary action, fluphenazine also antagonizes the alpha-adrenergic muscarinic histamine receptors. Same group of receptors we talked about before. So as you can see, in the case of the typical antipsychotics, definitely D2 receptors, mainly blockade of those receptors. And next, let me go through the atypical antipsychotics. So look here. Clozaril is sort of like a class by itself. It's a very important antipsychotic that we need to sort of understand. But look at the receptor profile here for the atypicals, right? So it has a high affinity for D2. So of course the blockade here you're blocking the serotonin you're blocking the serotonin receptors, right? Okay, you have the alpha adrenergic receptors here, histamine receptors, muscarinic receptors, and weak antagonism between receptors 1 and D1 and D4. So Clozaril hits a number of these receptors, and so you can see how it could probably be effective in treating a range of symptoms, including psychoticism, agitation, things like depression, restlessness, irritableness, and things like that. But Clozaril is in its own class because it's a high risk of causing agranulocytosis. And agranulocytosis is a very serious problem. That's why you have to have structured monitoring on Clozaril, like weekly for a certain period of time, then bi-weekly, and then monthly, and then and then you have to register for a Clozaril registry. So people follow clients on Clozaril to make sure that they're safe. So remember, if you're going to use that medication, it's probably because you've had maybe 2 or 3 failures on other medications, and this is probably the one that's going to give you the most benefit. But Clozaril is definitely in a class by itself, and none of the other medications really have that same risk for profile to be monitored like this. And from my experience, these medications have been very safe. So look at Risperdal, okay, D2 receptors and serotonin. All right. So one of the reasons why the different atypical antipsychotics are different is because you may want to block different combinations of receptors, or some of these receptors it may target more than others. So you want to sort of get a good idea of what you want to do, how you want to select your antipsychotic. If the person is tired and sedated, then you don't want to give them another antipsychotic. It's going to make it even more sedated. So you want to be very careful with the medications you're watching, because you want it to sort of match and complement the symptoms they're having, because ultimately you want to relieve the symptoms, right? Okay, and so Risperdal, look, it's dopamine and serotonin, all right? Zyprexa, a high affinity for D1, D2. Okay, look, Risperdal D1, here's the D2 high affinity with olanzapine. Also, significant serotonergic activity, right? Right. This histaminergic activity is thought to check me on this, but this may be increase the likelihood of weight gain because the histamine receptor, alpha adrenergic receptor, the risk of hypotension, right? Let's look at Seroquel, high affinity for histamine and serotonin, right? Antidepressant effects. Remember, atypical is also used for bipolar disorders, right? And so Seroquel has that huge affinity for the serotonergic receptors. And I wonder if that affinity is almost the same. I wonder if it's the same affinity degree as the SSRIs. And I wonder if the Seroquel have the same antidepressant qualities because it targets the serotonergic receptors as the SSRIs. So it would be interesting to look at the receptor profile binding affinity data to see if that's true. But I've always considered Seroquel very helpful in treating the depressed stage of a bipolar disorder. So if a person came in an outpatient office with depression and I wasn't sure if it were a bipolar disorder, then I would go with Seroquel because it has an indication for both of them. Particularly if I was concerned about if the antidepressant would be beneficial. Geodon, I like Geodon. Geodon works very well. Geodon, I see very few side effects from Geodon, D2 and serotonergic receptors. So they bind primarily serotonergic and alpha receptors. Okay, so with Geodon, you will have to rope the risk of increased prolonged QTC interval. So the increased risk of QTC interval, and so you have to get a 12-lead EKG with this. Next, Abilify. This is amazing. Abilify is amazing. Partial D2 blockade. It pops off. It has a peculiar sort of mechanism in serotonin. Okay, Latuda, dopamine and serotonin, Invega is the active metabolite for Risperdal. Okay, so Invega is the active metabolite for Risperdal here. Okay, so right now we're at 18 minutes. And let me see if anyone has any questions for now. I only wanted to have these 20-minute sessions so that it'll be shortened information packed. So let's see here. iHash, hello Doc, thank you so much, but Doc. Hey Maureen, how you doing? Let's see here. How exactly do antipsychotics block dopamine receptors? They simply occupy the binding site, and it prevents the ligand from reaching the receptor. That's it. Okay, so we're at 18 minutes here, so it's a pleasure talking to everyone. Read out tomorrow. I'm going to see if we can go through maybe the mood stabilizers or something like that as a category. I'll see, but I'll let you know. But otherwise, read out. It's been a pleasure talking to everyone. I'll talk to you guys later. Take care, guys. Ciao. Today we're going to go through mood stabilizers, and we'll go and look at the mechanism action of mood stabilizers. Mood stabilizers are very important. And we're talking about moods such as depression, things like mania, or mixed episode. So it's possible to have depressive episodes, manic episodes, and like mixed episodes. And with depression, you don't have to feel only sad to meet the diagnosis of depression. Irritableness can also be a symptom of depression. And in fact, I think I see people, my patients, presenting more with irritableness as the major component of their mood disorder as opposed to just sadness. So mood disorders are very important. Major depressive disorders, bipolar disorders, cyclothymic disorders, and dysthymia also. So I have here, let me go ahead and, okay, let me go ahead and just search, explain. So we're going to look at the antipsychotic mood stabilizers because, of course, the atypical antipsychotics like Seroquel, Risperdal, and all of them, they have an indication for bipolar disorder. But let's just look at the classic mood stabilizers like Depakote and lithium, right? So here we have lithium right here, anticonvulsants, great. And then we have the atypical antipsychotics down here, Seroquel, Risperdal, Abilify. And remember the difference between those typical antipsychotics is the typical antipsychotics are more potent and they more specific for the D2 receptor. And this atypical set of antipsychotics, they target other receptors, serotonin, norepinephrine, and that's probably why they also effective at treating mood disorders too. So here we have Seroquel and Risperdal, Abilify here, but some have mood stabilizing effects as well. Okay, but let's look at these main two. Here, lithium, which is primarily an anti-manic agent, and the anticonvulsants such as Depakote, Lamictal, Tegretol, Trileptal, and mainly let's look at Depakote and lithium. I mainly use Depakote for the depressed and mixed episode. If a patient continues to have these depressive manics or mixed episodes just continuously, like every month, it could be a process of rapid cycling. And so you want to make sure you put the Depakote at Depakote with lithium if you're suspecting that they're rapid cycling. And I sort of look at the Depakote for the lows and mixed episode and the lithium for the highs. Lithium is a salt here. It's an element. So lithium is a naturally occurrent element. Right? It's effective in treating both manic and depressive episodes. It works by affecting the flow of sodium through nerves and muscle cells to help stabilize mood. We're gonna see that mechanism later. Blood tests are necessary to monitor lithium. Lithium has that narrow therapeutic range. If it's a little bit too much, it becomes toxic and start to impact the kidneys. If it's too low, it may not have any clinical effect at all. So you have to get a blood level with lithium. Works very well. Okay, and look here, anticonvulsants. Okay, these medications are originally developed for seizures, but also have mood stabilizing effects. Valproic acid, Depakote, effective for rapid cycling disorders and mixed episodes. And so let's look at the lithium and Depakote as our main mood stabilizers. Depakote also has that therapeutic range, narrow therapeutic range too. If it's too low, it's not going to have much of a clinical effect. If it's too high, you get the Depakote toxicity. And we were concerned about the elevated liver enzymes in the face of Depakote and the possible hepatotoxicity it can cause. So with Depakote, you definitely want to check a Depakote level, and then you want to check the liver enzymes to make sure everything is going okay. All right, so let me look at, but there's something interesting about lithium and Depakote. Let me see if it'll go into it here. Now, let me see if it'll get into detail. Lithium and Depakote have two very important properties. Both of them result in down regulation of glutamate receptors, and it results in upregulation of GABA receptors. And so we want to change that excessive glutamatergic activity. So we'll download those receptors and start increasing the GABA receptors so we can sort of keep the system in balance there. So the lithium and Depakote cause a down regulation of those glutamate receptors. And that's what you want. Remember, in the case of bipolar or mixed and manic episodes, we're concerned about the combativeness, the agitation, the aggressiveness, and things like that. And so we definitely want these medications on board. Okay, lithium is widely used as the effective mood stabilizer, particularly for bipolar disorders, considered first-line treatment, especially for preventing manic episodes and reducing the severity and frequency of mood swings. Yep. The exact mechanism of action is not fully understood, but it is believed to act in the central nervous system by balancing certain substances in the brain that regulate mood, behavior, thoughts, and it may influence neurotransmitters like serotonin and dopamine. Let me look into that a little bit closer. It may say it. Okay. It's for bipolar disorder, off-label use. What is it? Major depressive disorder. Often, lithium may also be prescribed off-label condition for major depressive disorder, and is often augmented therapy with antidepressant managing bipolar disorder. I'm sure lithium is a really good augmenting agent. Okay, dosage. Lithium comes in various forms, including capsule, tablets, extended release, and solutions. Great. Capsule, tablet, extended release, and solutions. Okay. Side effects. Kidney damage. Thyroid. So remember the renal insufficiency, the kidney issues, and then hypothyroidism in the thyroid. Lithium toxicity can induce nausea, vomiting, trembling. Yeah. Blood monitor interaction, hydraulic effects. Okay, let's see. Let me specifically look for the mechanism of action for lithium. Okay. You asked for it. Okay, lithium's mechanism of action in treating bipolar disorder is complex and not fully understood. Okay. Okay, I think this can be seen better here. Okay. Okay, here's the breakdown. Here's the breakdown. Okay, glutamate. Lithium actually stimulates NMDA receptors, increasing glutamate availability. However, chronic administration leads to NMDA downregulation and modulating glutamate neurotransmitter. It also has a dual effect on glutamate receptors, keeping glutamate levels stable. I didn't know initially it stimulates the receptor, then it leads to a downregulation of the receptor. Yeah. And when I think about using lithium in the manic state, that's exactly what we want. We want to downregulate the receptors. We want to downregulate those receptors. Okay, let me see here. Okay, on monoamines. Okay, lithium can affect both serotonin and dopamine. It may increase serotonin transmission through various mechanisms, potentially contributing to the anti-suicidal and anti-aggressive actions. It also been suggested to inhibit increased dopaminergic activity, potentially contribute to the anti-manic effects. So it also affects, and I'm just now paying attention to this, so I didn't even realize it had that much of an interaction with both serotonin and dopamine. So yeah, okay. So the intracellular pathway, okay, the PIP pathway, phosphatidylinositol pathway. Lithium inhibits the inositol monophosphate phosphatase enzyme in the PI pathway cycle. This disruption can affect neurotransmission mediated by the PI system, impacting mood regulation. Okay, so basically this phosphatidylinositol monophosphate pathway here affects that glycogen synthase. Okay, lithium inhibits glycogen synthase kinase, which is involved in various cellular processes like cell survival, neuroplasticity, and apoptosis. By inhibiting glycogen synthase kinase, lithium may exert neuroprotective effects and contribute to mood stabilization. Okay, phosphatidylinositol and glycosylphosphate, CAMP. Lithium can also affect the cyclic AMP second emission signature, which is involved in cellular response to neurotransmitters. Wow, it may influence the production of neurotransmitter factors such as BCL2 and B, brain-derived neurotropic factor. Okay, wow, interesting. Okay, neurotropic effects. Yeah, reduce oxidative stress, increase oxidative stress. Yep, lithium sort of have like a neuroprotective effect. And whenever I have patients with what I'm concerned about, impulsivity, impulsivity and things, I make sure I reach for lithium first because it can be very, very helpful in decreasing the thoughts of suicidal ideations and also in decreasing the unpredictable behavior and impulsive behavior. So lithium is very good for that. Other effects, ion homeostasis. Okay, lithium can displace intracellular sodium, reestablish the sodium electrochemical gradient. Okay. Neuroplasticity. By affecting the various intracellular pathway, lithium can promote neuroplastic changes, which are important for mood stabilization and long-term treatment effects. It's very interesting with lithium. And let me just go through some of the, explain the, let me see, adverse. Yeah, first, so we want to go through, because remember, we don't want to give it in pregnancy. So let me just go through this real quick. It has a narrow therapeutic index, meaning the difference between the effective dose and potentially toxic dose is small. Be careful. Careful monitoring. Okay, neurologic tremors, drowsiness, GI, nausea, dry mouth, great. Renal, increased thirst, polydipsia, polyuria. Up to 70% of long-term lithium users may experience excessive thirst and urination. Up to 70%. This is due to lithium's effect on the kidneys, interfering with the kidney's ability to conserve water. Yeah, increased thirst, polydipsia, long-term. Other weight gain. Substantial portion of individuals taking lithium may experience weight gain. I haven't experienced that often. I don't really experience the patient gaining weight on lithium. Hair loss, I have experienced patients describing that in lithium. Okay. Toxicity. This is serious. Narrow therapeutic window. Toxicity can be a sudden, chronic. Symptoms range from mild to severe. Blurry vision, seizures, dehydration, serotonin syndrome, thyroid problems. Long-term lithium use can affect thyroid function, leading to hypothyroidism or underactive hypothyroid, or less commonly, hyperthyroidism. So yeah, watch the thyroid, kidney. Prolonged lithium can cause, especially in high doses or with repeated toxicity exposures, can lead to kidney damage and impaired renal function. Regular renal function is crucial. So we want to, especially at high doses with repeated toxicity episodes can lead to kidney damage and impaired renal function. So you have to make sure that you don't hit them get too high with the lithium. Heart problems. Lithium causes mild reversible change in the heart rhythm. Yeah, it can interfere with it. It causes that heart prolongation at QTC interval. Cognitive impairment. Some individuals may experience cognitive effects and mental slowing, things like that. So, so you can see the side effects of Eversex and lithium. And let me say, Eversex lithium in pregnancy. Yep, Epstein anomaly, right? Lithium during pregnancy increase the risk of birth defects, especially cardiac malformations like Epstein anomaly, can lead to adverse outcomes such as premature birth, low weight, and neonatal disease. I think the Epstein anomaly is that bicuspid mitral valve. Correct me if I'm not. It's been a while, so look at this. So we're worried about the Epstein anomaly here. Okay, so I think we got that here. Next, let me look at the okay, let me see the mechanism after Depakote. So we looked at lithium, manic episodes, Epstein anomaly, cardiac hypothyroidism, the cardiac block, renal insufficiencies, renal issues, not able to concentrate the urine. The renal issues come about with repeated overexposure to toxic levels of lithium. Downregulate, basically inhibits NMDA and results in downregulation of GABA, downregulation of glutamate receptors. On this study, I didn't see them talk about the upregulation of GABA. So you can see how all of that narrow therapeutic window, and you can see about how very lithium is a very useful medication, and it's a salt. It's an element. So you should always think about that when you start seeing about treating long-term agitation, combativeness, and aggressiveness, things like that. So let me look at Depakote, the second mood stabilizer. Okay. Depakote, the brand name for valproic sodium, works through several mechanisms to stabilize nerve activity and prevent abnormal electrical impulses in the brain. Its therapeutic effect comes from the combination of actions that are not yet fully understood. Primary mechanism of action enhances GABA activity. Remember, there's two main neurotransmitters in the body, and these two neurotransmitters are present throughout all the tissue. Glutamate, which is excitatory, and GABA, which is inhibitory. When we see patients have difficulties with some of these disorders, we see the lack of inhibition. We see the brakes failing. And because the brakes fail, the networks become overactive, and we see the overexpression of glutamate. And so now you see the host agitated, combative, aggressive. And so somehow we're going to need to balance that system with another medication by targeting the other receptor that's present throughout the entire organism, and that's GABA. We try to enhance GABA activity right away by giving benzodiazepines. So here, the primary mechanism of action enhances GABA activity for Depakote. This is considered one of Depakote's main actions, right? It increases the amount of GABA, the brain's chief inhibitory neuron, right? By inhibiting the enzymes that breaks it down. Okay, so I didn't know. You learn something new every day. Remember that new day. So it inhibits and activates the enzyme that breaks it down. An enzyme. This raises the level of GABA, which calms and relaxes nerve cells. I thought it had more to do with uploading the GABA receptors as opposed to turning off the enzyme that degrades it. Like acetylcholine in that synaptic cleft. The acetylcholine esterase, it targets the acetylcholine and breaks it down. But I never realized Depakote worked with same enzymes that metabolize GABA. Okay, here. So next, blocking ion-gated sodium channels. It's an anti-seizure. Depakote is an anti-seizure medication, right? Depakote blocks the entry of sodium into the neuron, which reduces the excitability and firing rate. Hey, so it increases GABA by deactivating the enzyme that breaks down GABA, and then it blocks the sodium gate. It makes the neurons less reactive. This helps prevent a rapid, repetitive firing of the neuron that is characteristic of seizures. This is great, right? Inhibiting T-type calcium channels. T-type? T, how do you get all the way to T? Do you start from A? The drug blocks certain calcium channels, which are involved in the generation of abnormal electrical activity in the brain. This is especially important for treating absence seizures and conditions linked to those channels. Okay, yeah, so increase GABA activity by deactivating the enzyme that breaks it down, blocking the sodium channels to decrease polarization, to decrease the excitability of the cell, and then blocking specific type of T calcium channels. And I'm sure that decreasing the gradient there will actually make those channels less sensitive and decrease. That's the mechanism of decreasing the seizure-like activity. Okay, it's very interesting. Okay, other potential mechanisms. I'm not sure if I want to go into those. Therapeutic effects explained. Okay, epilepsy by inhibiting sodium-calcium channels. Yep. Also, enhancing calming GABA media, increasing inhibitory tone. Yep. Depakote prevents uncontrollable electrical bursts that cause seizures. This AI thing is really amazing because reading, it seems like reading this stuff now, it seems like it's so simple. It seems like it tells you everything in such everyday language. Okay, next, bipolar disorder. Its ability to stabilize neuronal firing and influence gene expression contributes to its effectiveness as a mood stabilizer, managing manic and mixed episodes, which may reflect overexcitation or excitability of the neuron. So that makes sense. Depakote would turn the enzyme off that degrades GABA and increase GABA's tone that way, shuts off the calcium channels and also stabilizes the sodium channels. Makes sense. Migraine prophylaxis. Various paths The various pathways it influences in the brain help prevents the abnormal neuronal activity it is thought to trigger in the head. Okay, that's great. So that's the mechanism of from Depakote. Let me see. What are the adverse? Explain the adverse reactions to Depakote. Yeah, let me look at some of these. Okay, let's see here. It's used to treat seizures, bipolar mania, migraines. Okay, like GI issues, neural issues, hair loss. We got those. Okay, here, liver damage. All right. And so we're concerned about the hepatotoxicity, pancreatitis, right? Now, we don't want to give it in pregnancy because of the risk of neural tube defects right here. And what is that called? A neural tube defect, spinal bifida. Heart abnormalities, which is could be Epstein abnormalities, decreased cognitive effects during pregnancy. Look, suicidal thoughts and behaviors. Okay. Bleeding problems, thrombocytosis. Yep. High ammonia levels can cause encephalopathy, right? Severe skin reactions. Now, there's another thing. They also have it down here. Depakote is also classified as it causes cancer. They use it to produce certain type of tumors, predictable tumors in lab animals. And so it's also used for those purposes. But let me look that up too. I don't want to just say it like that. Let me look it up. But here, yeah. So let's just look through here. So remember, we had several clients today. We have to look at liver enzymes. If liver enzymes are elevated, and you don't want to get into that story. You want to choose something else that's not metabolized by the liver, to go around the liver. If you have patients with liver damage, you don't want to use Depakote. Pancreatitis, you don't want to use in pregnancy because of the risk of spinal bifida. You have to watch out for agranulocytosis, have to check ammonia level. And the ammonia level could be sort of like an indication that the person is having more of an altered mental status. In the medical world, they'll call that a metabolic encephalopathy. In psychiatry, we'll call this a altered mental status, and also a delirium, whether or not it's going to be a hyperactive delirium or a hypoactive delirium. So this encephalopathy could be a result of elevated ammonia levels in patients on Depakote. Okay. So we want to consider the elderly and things like that when you use them. Okay. So I did the mechanism, the adverse effects. I think that's it. I don't think it's 27 minutes now. I don't want to go too long for this, and maybe I should be able to answer a few questions. Okay, guys, so let me see if I can take a few questions, if you may have a few questions. Okay, so let me see here. Okay. Hey, buddy, how's it going? Good to see you, Doc. Good to see you, buddy. What are mood stabilizers and how do they differ from antidepressants and antipsychotics? Remember, the antipsychotics, the atypical antipsychotics also target dopamine, serotonin, norepinephrine, and things like that. And so they can be very effective in treating the mood disorders like bipolar. So many of them, like Seroquel, Risperdal, Abilify, already have the indication for treating bipolar disorders. And I would go with those first if you're in an outpatient setting. But on the inpatient setting, when the symptoms are more concrete and very persistent and very, you're concerned, then you want to go with the mood stabilizers like Depakote and lithium. We just reviewed the subjects of antidepressants yesterday, and we basically discussed how they block the reuptake, they block the reuptake inhibitor pump, therefore increasing the amount of serotonin and norepinephrine in the synaptic cleft, and therefore increasing the transmission of those serotonergic and norepinephrine networks. So the mechanisms are basically still the same, but different molecules interacting with the same type of structures. Mm-hmm. Hey, Umber, how's it going, buddy? Do mood stabilizers have a role in preventing neurodegeneration? It'll be hard to prevent neurodegeneration, but all of this activity could result in the point in the production of brain-derived neurotropic factor, and I think that's where you're going to get the neuroplasticity. That's where you'll get the learning and things like that. Preventing neurodegeneration is things like I would call someone who's not living up to their capabilities or withering away. Great. Okay, Dr. Liv, correct. Epstein, it affects the tricuspid valves. Thank you so much. So it's a tricuspid valve, not a bicuspid valve? Correct me, let me know. Thank you so much. Mahai, how you going, buddy? Appreciated this. Medical and coding knowledge, keep supporting. Thanks, buddy. iHash, how you going, buddy? What's the main challenge in prescribing and monitoring mood stabilizers? Getting a blood draw, the administrative structure that's involved in managing the care around this. Sometimes the clients may not have the cognitive ability to manage the appointments, to remember the labs, to attend the lab appointments, to have resources. And these are a lot of complicated things for people to do. Getting labs and following up with the treatment is a challenge. That's why you don't have to get the blood draws with the atypical antipsychotics, right? And the atypical antipsychotics are not really associated with the same side effects like Depakote, hepatotoxicity, agranulocytosis, and things like that as side effects. And for lithium, kidney problems and thyroid problems as side effects, whereas with atypical, they're classified as antipsychotics, but, you don't have to get all the blood draws or all the administrative work that goes along with them. So I would go with the atypical antipsychotic first for these disorders, and then use the mood stabilizers when it gets really intense, when you need some backup. Okay, great. Okay, Ms. Watts, since lithium and Depakote are not used for every episode of excitability across all diagnoses, I am curious to know the brain chemistries during mania to see if it correlates with the sodium-calcium channels. Think about this. The mania increased glutamatergic activity. Somehow the threshold of an action potential being lowered, and the network is just on overdrive. That's what I would probably anticipate is happening down there at the molecular level. It's an interesting story to try and explain this at the molecular level. It'll be a very interesting story. Okay, so right now we're at the 32-minute mark. I didn't want to go too long. I want to try to limit these talks to 20 minutes. Went over, but it's a pleasure doing these. Let me know if you want me to cover certain topics. You just in the chat, just let me know, and I'll stay on those topics. I wanted these sessions to be very helpful for my patients, for their families, and then for the students who are learning. So if you have want to give me any input on these, I'll be glad to take it. But I'm trying to keep it 20 minutes, and I'm trying to keep the language in everyday terms, so it can be approachable to my patients and their families. Okay, so it's a pleasure talking to you guys. Read out. I'll talk to you guys later. Take care, guys. Read out.